Good morning. We'll get started in just a bit. Good morning, and thank you for joining. We're going to get started in just a minute, waiting for a couple more folks to hop on the call. Right, good morning. Happy Friday, everyone. Really happy to welcome you to the 2026 AI Cohort Series brought to you by the California Telehealth Resource Center. We're really glad you could join us today for our session titled Harnessing AI to Advance Maternal Health Outcomes. I'm Rebecca Brooks, Executive Director of the CTRC, and I will be your moderator for this session. Go ahead and jump to slide 2. Thank you. Want to just provide a disclaimer that this session is purely for informational purposes. CTRC has no relevant financial interest or arrangement with any organization related to commercial products or services discussed during today's session. Also, for those of you who are not familiar with Microsoft Teams, here's a quick run through. As you can see here, there are some tips, functions. The chat is available. Please, we hope you use it liberally. We have a smaller group today, and we can facilitate a lot of great discussion and answer any pointed questions that you all may have. Also, feel free to engage with each other in that chat. You can raise your hand or react if we have some opportunity to come off of mute, which we'll have Q&A later. Please ask those questions. And just as a reminder, you are muted upon entry. So if you come off of mute, you're going to press that button and then please remute yourself for everyone's sake. And then do want to call out that this session is being recorded. So please keep an eye out for attendee announcements of when these recordings are available. We would love for you to share them with your colleagues or anyone else you think would benefit from this content. Also really want to thank you for our funders who have not, without their help, this would not be possible. We do have funding from the Health Resource and Services Administration Office for the Advancements of Telehealth and the California State Office of Rural Health, part of the Department of Healthcare Access and Information. So big thanks to HRSA and HCI for the support here. Now, I'm thrilled to introduce you all to our speaker for today, Dr. Melissa Wong. Dr. Wong is a practicing physician at Cedars-Sinai, an assistant professor of obstetrics and gynecology, and first author of a study published in the American Journal of Perinatology on using machine learning to predict vaginal versus cesarean delivery. Her work focuses on supporting clinical decision-making during labor, setting patient expectations earlier, and ensuring AI tools are transparent, interpretable, and clinically useful. And with that, Dr. Wong, the floor is yours.
Awesome. Well, it is so grateful to be here and be able to talk to everybody. I'm going to go ahead and share up my screen here. It sounds like you guys can hear me okay, and just get a confirmation that y'all are seeing the screen okay. All right. Awesome. Perfect. All right. Well, then, without further ado, so I have the exciting task of sharing with you sort of how we, I'm going to say, should, somewhere in there, be harnessing AI to try to advance maternal health outcomes, perform. I'm going to start by saying that I really have no disclosures, but I am going to add this one, I think, important preface, which is that, we're not going to solve all of AI today or answer all of our questions around AI. And if anything, my goal is to sort of leave you somewhat more confused and asking questions about the right things, rather than necessarily having, sorted out how we fix all of AI or all of OB in all fairness. So the talk is sort of divided into these 3 parts. First, I'm going to give you a little bit of a broad overview just so we can get some vocabulary together about how to talk about AI in general. We're going to go into sort of where AI is making some of its inroads into clinical care. And then finally, what I think is honestly most pertinent, which is that like very few of us here are going to be designing the AI from the ground up, but much of it is going to be sort of offered to you or presented to you. And sort of how do you look at that AI and understand whether it makes sense for you, for your patients, whether it can actually enhance your care. So without further ado, then starting that initial intro bit here with what is artificial intelligence. And this is how Garry Kasparov, the very first chess grand champion to be bested by an artificial intelligence computer, described what he thought AI was. But I think we can probably go a little bit deeper than that. So this is kind of one of my favorite definitions of what AI is, which is put really simply, just what we used to think required a human brain and using a computer to do that. Or sometimes I described as sort of agents perceiving the world around them, making plans, and then putting into place decisions to achieve that goal. And so if that's our sort of overall big bucket term of artificial intelligence, the most common subset that you're going to see is what's called machine learning. And that's where instead of us, building the model and telling the AI what to do, instead the computer is really building the model itself. So instead of us programming explicit rules, it's identifying the patterns. It'll oftentimes do this for classification problems, so telling one thing from another, or prediction problems. But either one, it's really this idea of using existing data from the past to generate new rules that can be applied to new things. It can do so via supervised learning, unsupervised learning, or reinforcement, or some of the other vocabulary terms that you'll see. And then, so to put this in sort of context, then, this really, in my mind, represents a real shift in the way that we sort of used to use our compute power. So if we take, for example, any sort of clinical calculator, from my field in obstetrics, I'll take something like the vaginal birth after cesarean calculator. So the way it used to work was that we sort of like get a bunch of human brains together. We'd say to ourselves, okay, I think that this, and this matter, probably how big the baby is, why they had the C-section last time. And I'm going to click my little drop downs in the computer, give it all of this patient-specific data, and then the computer is going to give me the answers. What's happening now instead is that I'm in fact giving the answers to the computer. I'm giving the computer the data, and now the compute power is being sort of put towards generating the model, either with or without my direct help. And I'll highlight this too because it can also be very much without. So this is sort of that black box conundrum that comes up that many worry about when it comes to AI, because in these deep neural networks, for example, it's really intended to sort of mimic the brain. At the end of the day, it's really lots of regressions with just sort of feedback up the axon. But at the same time, we often can't unbox these. So we can't actually see the equation that generated the right prediction. We just know that the right prediction was generated in the end. And then looking at another category within AI, natural language processing, we've actually had for quite some time now, dating back to like Noam Chomsky translating Russian. But what's changed is increasingly sophisticated techniques, including deep learning, that have made NLP sort of move us into this newer field, which is something called generative artificial intelligence, which I think by now everybody's heard about. It's what drives things like ChatGPT. And I want us to think of generative AI as really the inverse of predictive modeling. So where predictive modeling or discriminative was sort of find the discriminatory boundary, whether it was in the form of an equation or a fancy model, it was this idea of sort of predict the label given the underlying features. Generative modeling is sort of the opposite. It's predict the features given the label. I often describe this as really just predict the next most likely word or thing. And that's really it. So it is, we've actually had generative modeling for years. If you think of sort of like weird autocomplete fails, all of that is being informed by generative artificial intelligence. And in fact, some of the first generative AI splashes were actually in the form of image generation. So this is from DALL-E back just a few years ago, what some would call AI art, like this rendering of Keanu Reeves performing an obstetric ultrasound, which I would consider, in fact, not art per se, as much as the stuff of nightmares. But these image generators, of course, as we recognize, especially in this era of disinformation, have improved dramatically and are now the source of a lot of disinformation worries, since now truly anyone can generate their own image of Forrest Gump as played by Magic Mike explaining gestational diabetes. You're sort of looking at that thinking, I would watch that movie actually, but tragically it is not real. But again, what of course really brought generative AI to the fore was ChatGPT and the similar models like it. And in fact, the wild innovation, I would say, of the last few years wasn't the existence of this generative AI. Again, we've had autocomplete, but rather the relative democratization of it. So these generative pre-trained transformers, that's what the GPT stands for, takes this ability to predict the next word and puts it into our hands such that we can get questions like this, like write me a maternal fetal medicine consult note that can be both simple and complex, and get these answers, which can be impressively correct sounding, at least, and often impressively correct. But it's also at the same time really important to reflect where these still struggle. So, for example, in an engine built to predict the next most likely word, it's not a surprise then that it struggles with a basic math. Do it, and it comes up with this really obfuscated answer. And then finally, in the last of our sort of vocabulary terms, agentic AI. And this is really all the rage in the AI community. And in brief, it's the idea of not having one AI, but an AI system filled with individual agents that can take independent goal-directed actions rather than just responding to a single prompt. So in healthcare, for example, it might mean having one AI whose primary job is to perform the medical interview, another language model built just for drug safety, another one, built just for sort of checking patient perspectives. And each one contributes their own quote unquote perspective. And so in many ways, it's sort of intended to mimic this kind of team approach to solving a problem, not unlike the team of experts that might come together on morning rounds. And so then coming now with that backbone, where are the ways in which we've sort of seen AI make its inroads into clinical care? And the long and short of it is that, compared to over 20,000 drugs that are FDA approved, AI is still relatively nascent. So if we look at the number that have really reached this stage for the FDA, there's only about 1,500 total. And admittedly, that number has increased dramatically even in the last year by almost doubling. But there are about 1,500 total FDA approved or cleared software. And even within that, the reality is that over 3/4 of it are radiology based, another 10% are cards. And as we sort of slowly roll our way all the way down there, if you can see at the bottom of the list, OBGYN has all four, three of which are fertility. And so while that's kind of the landscape, I would say, of those that have really made it to the finish line, this wouldn't be a very fun talk if I was only talking about four things. There are several examples, I think, of what is kind of in the pipeline of what's up and coming. And so I've sort of divided the applications of, clinical AI and how it might impact maternal health into these fields. And we're going to kind of start closer to the bench with things like drug discovery, diagnostic testing, and then nudge a little bit closer to the patient with, surgical or procedural uses, operations-focused AI, including patient-facing in-hospital and remote patient monitoring, and then finally aspiring really to that magical sort of pie-in-the-sky goal of true personalized medicine. So starting then with drug discovery. So drug discovery, just the research and development piece alone, is a $260 billion market. And not surprisingly, I mean, this was sort of the traditional way, was that you would identify this biomolecular target, sure, simple enough. You would then literally kind of hunt, forage, and build this giant molecule library, and then pipette those molecules into little wells and see if it worked. And then eventually to preclinical and then clinical trials, where you do kind of recruit via buckshot method, wash, rinse, repeat, and then maybe at the end of that, you'd have a drug. What drug development looks like now is already extremely different. So AI is now being used for target identification, molecular design, drug database analyses, even natural language processing for literature review. And in fact, one of the more recent examples, and one of the ones to make sort of the biggest splashes, was in antibiotic discovery. And so again, the old way used to be that you would kind of drum up a bunch of possible antibiotics. You would maybe get a 5% hit rate on a bacteria. Instead, what newer groups have used, including the one published here, was to use AI to evaluate the Center for Development of a Therapeutic Drug Repurposing Hub, which is basically about 6,000 molecules that are either in clinical trials or have already been approved. Using deep learning, they were able to demonstrate a hit rate instead of 5% to about 50%, so increasing that hit rate tenfold. And in fact, one of those drugs that they found had a mechanism completely different from all the other antibiotics and was able to kill E. coli, including the pan-resistant Acinetobacter, And they actually named this completely novel antibiotic Halicin as an homage to the 2001 Space Odyssey computer, but was really the first new antibiotic developed in decades and was done so with AI. And what I will say is that while that's not within OB, while all of those ID and folks and cancer folks might get these like sort of novel therapeutics, I do expect it to look different in OB. And so this is the single example I was sort of finding for drug discovery in OB that's still very, very nascent. But again, instead of using those sort of like computational drug repurposing things or developing their own sort of personalized molecules, instead, what they're doing in this group is actually using some of the, expectations with drugs that already exist and trying to use sort of the underlying protein targeting to try to sort of connect the two dots. And doing so in this particular focus on preterm birth prevention, they found 4 potential candidates, including among them lansoprazole, of all things, which might have activity in reducing the likelihood of preterm birth. Now, is this ready for prime time? Absolutely not, like not even close. But I do think it is where we start. And I think it's what things are going to look like in OB. If you think of like that sort of like, molecule to drug on the market thing for any old drug, thinking of that in pregnancy is like really explode your brain in terms of how long that takes. So I think that this is where we actually get closer by taking things that we've already been recommending and seeing if they have this sort of like reappropriating potential. Moving on then to diagnostics. So this can span everything from like medical imaging, radiology and pathology, consumer imaging, things like dermoscopy and ophthalmology, to even predictive disease modeling. And so in the vein of diagnostic performance augmentation, again, you're going to kind of see this trope where I have to kind of draw from something else. I'm going to highlight this Masai trial because it really represents one of the few true randomized controlled trials of clinical AI, frankly, more broadly, and the only one that's in women's health. And what I highlight here is that the standard of care, especially in a lot of countries, among them where this study was done, the standard of care for doing a mammogram and reading it is really double reading. So every single mammogram, in other words, passes through 2 sets of eyes. So double the amount of time, effort, cost, availability. And what they did was to basically score that versus an AI augmented process pathway. And so the main point of this initial 40,000 patient population was to study to evaluate its impact on workload. And not shockingly, it resulted in significantly lower screening workload. In fact, it cut the overall read time in half. Even more exciting were these results published just a couple of months ago of the final outcomes from the trial, now with its total recruitment of just over 100,000 patients, where again, their aim was to demonstrate not only could they cut that workload, but could they maintain non-inferiority of patients developing cancers in the meantime. And in fact, that is exactly what they did. Here, sort of a much prettier visual abstract form, that this AI augmented read of the mammograms was not inferior to 2-reader eyes, and if anything, signaled towards fewer cancers. So again, not pertinent per se to OB, but I want to highlight that this is what these diagnostic trials, especially for imaging augmented diagnosis, should look like. So then, without sort of keeping you waiting, where have we gotten, as it pertains to OB diagnostics? Well, most of the work for this really has been done in obstetric ultrasound. So this is a classification I'll borrow from Dr. Drucker here, where he sort of divided it into operations-focused AI, education-focused AI for OB ultrasound, and then anomaly detection. And operations might be everything from sort of like the auto measuring that some of you might have seen, coming up, trying to show you a femur length, education to teaching novel skills. So for example, actually teaching our learners, whether it's sonographers or clinicians, how to actually move the probe to do things differently, all the way to sort of those pie in the sky goals, again, of anomaly detection and being able to apply that in the screening sense. And so focusing on some of these, this is one group that performed this kind of AI augmented study. And this group out of SonarNet was able to demonstrate that they were able to complete a full level 2 anatomy ultrasound using artificial intelligence. The top row there is basically what the sonographer chose as their best picture of the pictures they took, and the bottom picture was what AI chose. And granted, what I will highlight is that this is all done in retrospect, right? So by definition, a sonographer's hands sort of pass through all of those planes in the first place. At the University of Oxford, they thought they'd level that up even a little bit more by adding eye detection using AI to follow the sonographer's eyes. The sonographer, in this case, was sort of had these little special glasses on. They followed where their eyes were looking. And as you can see here, for those of us who do some ultrasound, on the left, that's kind of an irrelevant plane. You're just kind of like working your way through the abdomen. Their eyes are relatively at rest. Whereas on the right, you're right approaching where we take one of our critical measurements, the abdominal circumference, and you can see the sonographer's eyes are sort of reflecting that. Their eyes are sort of darting around, making sure I've got only one rib on each side, I've got the stomach in plane and so forth. And the computer now has learned, oh, okay, I should care about this plane, and so highlights that in particular. And I'm going to highlight one more, not because it's amazing per se, because yay, we're detecting ultrasound planes just like all of the others, but because of what they then did with the data. And I think that if we're going to get anywhere with AI broadly, and particularly when it comes to imaging, this is what it has to look like. So they published their model, they got their cool little sort of publication credits, but then they also shared the nuts and bolts of their model itself. And then they actually shared in a de-identified fashion, of course, these source images, right? And this is what it has to look like for us to get anywhere in terms of moving the needle forward for image detection AI. But then how about coming back to that sort of like uber goal, like actual like anomaly detection and diagnosis? So this was a nice study done by Z et al, where their aim was to use deep learning for neuropathology. And in fact, they were able to identify that. So you can see here, these are abnormal planes, and the AI comes with this little heat map to say this looks weird here. But then on top of that, they actually demonstrated not only could it identify where it looked a bit odd, but actually that the actual pathologic diagnoses. So you can see here some of the more common things, agenesis, holoprosencephaly, demonstrating an ability to classify these abnormalities with 96% accuracy. But then making it even further down the pipeline, this study by Arnaud et al. Used ensemble neural networks to look at fetal congenital heart disease. And as many of you may know, our sort of baseline sensitivity for identifying fetal congenital heart disease, one of the most common fetal, congenital birth defects, is unfortunately only about 30%. At best, maybe at academic MFM centers, 50%. Using their neural network, however, they were able to achieve a classification index of an AUC of 0.99, a sensitivity of 95%. And again, those numbers are distinguishing normal versus abnormal, but I would actually make the case that that's what you need, particularly whenever you consider rural settings where they might not have access to an MFM, certainly not even an MFM, let alone like an OB per se, where the real question is, can I send this person on versus do I have to refer them more centrally? They also, what I like about this group is that they actually did external validation of their data, lesser machines, different site, and it would perform just as well. But again, all of these have been in the hands, particularly of expert sonographers. So what happens without that first element? And that's really what this group focused on. Their goal was gestational age assessment. And so they sort of did step one, where they trained this machine learning model on that first NEJM paper of about 4,500 scans to do assessment of gestational age, which any of us who does OB knows is critical and oftentimes really hard to achieve, particularly in our underinsured population who might not get care until the second trimester. And then the second part of this was to actually put it in the hands of birth workers who had never performed biometry and have them perform totally blind sweeps. And when I say blind, I mean completely blind. This is like in birth workers in Zambia who had never held an ultrasound before. And the screen, as you can see there on the iPad, is nothing other than instructions, like put this over the pubis, move it upwards, and then click next to take the next picture. And what they found in this study was that comparing sort of the index versus the reference standard, which is using big fancy machines being wielded by an expert sonographer, there was absolutely no difference in overall gestational age assessment in mean squared error over 400 scans. And I bring this up to highlight not because this is a global health study, but rather because we have these same problems here. In the US. You don't have to go to Zambia to not be able to access first trimester care. And so this ability to potentially improve population health using AI, I think is something that we should pay attention to. And then next in the surgical and procedural setting. So I would say that AI has been in our ORs actually for a while. So many of us who, we're generalists will perform, robotic hysterectomies, all of those haptics. You're not actually feeling things. That's the AI generating that. It's what's preventing you from flinging the third arm across the room. The new frontier, though, is really this idea of computer vision augmented reality. We, of course, don't have real great examples from OB yet. So I'm going to borrow this one from GI, where they have now several different ones, where essentially they will have augmented adenoma detection during your colonoscopies. And there are, in fact, so many companies or studies that they've actually had the ability to perform these systematic reviews and have, in fact, found that it does increase the adenoma detection rate, although possibly at the expense of one more biopsy per colonoscopy. And I would say, again, still not an OB, but at least across the hallway, perhaps, the closest that we have to that computer vision are groups trying to use computer vision to highlight endometriosis, such as this from the Gynecologic Laparoscopy Endometriosis Dataset, or GLENDA, an image dataset containing region-based annotations of 350 images from over 100 different surgeries, where the goal, again, is really to help us. So you might, have clinicians who only do one endometriosis surgery a month or even, a couple a year. And so can that person necessarily detect as well as the person who, does, 5 of these a week? Perhaps not. And so the goal here is to say we can augment that sort of hunt for those little subtle powder burn lesions. And so these data are still very early days, but I do think it represents where we could kind of go. Within OB and specifically maternal health, I would say we're still, sort of surgery adjacent. And actually, this was one of the more interesting studies that came out looking at the postoperative period. And also, I like because it lives squarely in this telehealth space, which was potentially using AI and computer vision for postoperative wound complications. So this was a study partnering out of Rwanda, I believe, partnering with Harvard to give community health workers smartphones to aid in identifying postoperative wound infection. Again, they haven't published sort of anything further from this. It's very early days. This isn't an app you can download or anything like that and start handing out. But the lab also, I will also point out, has a whole paper around the implementation challenges of this, including like which smartphone they have, how the lighting is. You can see here they sort of put that little rubric around it in order to standardize across, white balance and things like that. But I think, again, represents anything in OB that we can be excited about related to AI. Moving on then to operations. And I will say that operations and, rev cycle management, all of those things, this has been happening for a while. If you look at things like insurer risk stratification, at Cedars from like literally, I don't know, like week 2 of COVID, we had COVID census predictions going, length of stay predictors, patient experience predictors even. And all of that was before generative artificial intelligence. So again, the engine that's running things like Chat GPT. And if there's any indicator of how much this is sort of impacting operations, probably fewer more indicative than this somewhat, I'm going to go with disturbing image from the 2024 general meeting, although I was just at the 2026 general meeting and it looked just like this, of the largest EHR company in the US, and it was devoted to all the new Gen AI introductions in the next year. And this screenshot from Epic's own sort of backpatting for what exists now, many of which have been turned on in our system, and I'm happy to sort of talk you through the pains and glories of each of these. But operations has been a huge focus, particularly with generative AI being on the fore. And so with so many opportunities, as we sort of get squeezed from so many different directions, I think it's reasonable to also ask ourselves which of these actually helps. So which of these AI technologies has actually demonstrated any benefit. And in this case, because it's operations focused, where I would suggest we should be paying attention to doing things like reducing clinician burnout. And admittedly, we're actually not the first to ask this question. So there are scoping reviews on this topic, not only of just physicians, but of other healthcare workers. And the only one with actually any true randomized controlled data, trial data to back it up, are actually digital scribes or ambient note-taking AI. And so what I'm going to focus on here are 2 randomized controlled trials, both published in the same journal, NEJMI, and both which had similar results. The first was a smaller study of 66 clinicians, multiple specialties. Their primary outcomes were professional fulfillment and work exhaustion, as measured with the Stanford Professional Fulfillment Index. And what they found is that over time, with access to the AI scribe, in blue, you see the reduction in exhaustion and interpersonal disengagement. And in red, a statistically non-significant but increase in professional fulfillment that did persist over the entire study period. A second study done at UCLA, a larger study of 238 physicians with a 3-arm randomized controlled trials because they were trying 2 different scribe platforms. And their primary outcome was time and note, but they also secondarily looked at burnout indicators. And interestingly, while they trialed 2 different scribe platforms and showed a reduction in time and note in only one of them, they showed signals in reduction in burnout and physician task load actually for both, suggesting that it's not just as simple as a metric of sort of time spent typing that actually captures the source of all of our ailments, because actually both reduce burnout. But I also want to take this all with some degree of balance. So this study that just came out a few months ago, I think presents a little bit more balanced take. It was done at 5 different institutions across over 8,000 physicians. And what they found in this table was that adopting AI Scribe did result in 13 fewer minutes of total EHR time per day, which, I mean, sounds good. 13 minutes is not nothing, but it's also not a lot. But incidentally, it did not change their time spent in work outside of work, the pajama time, as we might call it. So they are still spending just as much on pajama time. And also notable, and maybe even a little disturbing, that it increased actually their weekly ambulatory encounters by half a visit per week. And so this is the calculus that we sort of have to ask ourselves. Like, nobody told these people you can have a scribe if you see more people. But nonetheless, despite that, we sort of fill the time with more, and thus sort of increase our cognitive load in different, and one might make the case perhaps more taxing ways. I will say anytime we talk about digital scribes, consenting the patient is essential. And I think this has been demonstrated rather consistently that we have to do this every time, document it every time. And I was actually really excited to see that y'all have a guide on this and are really leading and pulled this straight from the website. So I really encourage, sort of maintaining this practice. Moving on then to patient monitoring. So this is in some ways both a mature and also continuously expanding category, and I think reflects this thirst for this from both patients and clinicians. I mean, how many of your patients, today versus 5 years ago are wearing an Apple Watch or a Fitbit or some sort of a tracker that's giving them all of this data, and who the heck knows what to do with it? And I'll actually say that my first sort of like magical moment in AI monitoring integration was really patient driven, the initial, what we now call closed loop monitoring for diabetes, but the artificial pancreas. And again, just speaking to how patients feel about this, it originated not from industry, not from scientists, but actually from patients who were hacking their own continuous glucose monitors and pumps to to talk to their pumps and then titrate their insulin. And then they were going online to GitHub and sharing their code with each other and saying like, oh yeah, if you've got the Medtronic this, and then you have this pump, you can put these 2 together. Now, of course, closed loop insulin management is commonplace, but it really reflects this sort of thirst for patients to say, like, we want this sort of ongoing monitoring and ongoing sort of feedback loop. And so in terms of where we are in, oh, sorry. I don't mute there. Sorry, I'm on service. All right. Where we are in terms of our monitoring, I'm going to sort of say that most of the work, admittedly, in AI monitoring has been done in the vein of fetal monitoring, sort of, the 2-patient version of monitoring, I guess. And I'm going to group these also into say that there's really 2 categories. One of them being sort of the alert system, i.e. we know what matters, category 1, 2, 3 for tracings. And then what I'm going to call kind of real AI. So sort of trying to discover what it might be there that our eyes are not able to see. And I'll start with the alert system, and there's several different versions. The most common one in the US is going to be PeriGen, and say that this is relatively easy to understand. You basically like see the decel, a little colored bar comes up for the deceleration on the heart rate tracing. And we'll also say that this has unfortunately been studied. So this is the biggest study looking at this, the infant system, which runs very similarly from the UK and over a decade ago. And they have these little colored signals bars for good and bad. They set this up as a beautiful multinational, proper, giant randomized controlled trial. And what do they find? Absolutely no difference. No difference in mode of delivery, composite neonatal outcomes, parents' eventual scores of how awesome their kid was. Just no difference at all. And in some ways, I would actually make the case that having no effect in this context makes some degree of sense, right? You're basically got a second observer working off the same manual. Like, we are all paying attention to the tracings all the time. That was probably not the issue. On the other hand, what might become more compelling is the idea of novel findings in this context. And this has really started to make its way more into the literature in the last few years, this idea of applying deep learning to fetal heart rate tracing detection, being able to achieve sensitivities and positive predictive values, which in fairness are okay, they're like 70% and 3%, but which are also consistently better than our baseline sensitivities and positive values in the hands of clinicians. So the science is still quite nascent for all of these, but I will say it has also gotten industry all into it. However, what I will segue quickly back to that gives, especially given that this is a maternal health talk though, what I want to highlight at least is where I think there is wild potential in maternal health, which is in remote monitoring for hypertension. So I would suggest that it's now pretty near established that some version of postpartum remote blood pressure monitoring improves outcomes for our patients with either, gestational hypertension or preeclampsia, whether that's in medication titration, time to control, pick whichever metric, they pretty much all do better. But what hasn't been done is anything to actually better enable us to take care of patients. You ask anybody what work this takes to set this up, and they basically point to one champion who worked really, really hard, right? And each of these studies in that systematic review from the previous stage was sort of variations of the same with maybe varying degrees of technology. Whether, transmission was directly handled by a human, with the only tech being that it came via text message, or maybe had a little threshold alert built into the inputting mechanism itself, or at most had a clinician still providing oversight to the app. What we have not harnessed is the ability for AI to actually recognize trends. It's one of the things it does great, recognize trends, summarize, and recognize therefore that blood pressure management does not have to be one size fits all. And in fact, we as clinicians do not manage it as one size fits all. We recognize that there's a really big difference in, seeing the same systolic blood pressure of 160 in the chronic hypertensive who kind of hangs at 140s, 150s the whole time, who we can, potentially just keep at home and do gradual titration versus the totally new onset preeclamptic whose blood vessels are used to living at a systolic of 90. And so you can use AI to really generate those personalized risk models and then give that personalized feedback. And then where the clinician's role is a little bit different, but providing general oversight. Which I think is a great segue to bring us to our final category here, sort of truly all the way from bench to bedside to that real pie in the sky goal of personalized medicine, where this sort of like gray house here is not this nostalgic farmhouse, but rather this nostalgic farmhouse, an AI-driven individualized treatment plan, taking into account the person's underlying biology, their natural history, to permit personalized risk stratification, earlier diagnosis, and precision treatment plans. And there have been huge strides in this in genomics and cancer care, but what does that look like in OB or maternal health? So I'll start with predictions, and I'll pause to say that when I first started exploring this space, so we developed our initial machine learning model between about 2017 and 2018, there were like all of 36 results total in AI for maternal health. Fast forward now to 2026, and let me tell you, it's a little different. Machine learning models will now claim to be able to predict preeclampsia, whether you'll have a shoulder dystocia, whether you'll VBAC, whether you'll VBAC in sub-Saharan Africa, and even whether you'll develop postpartum depression. The literature is so vast, in fact, that we published a scoping review back last year, which is undoubtedly already wildly out of date. And it's sort of the equivalent of assessing, all of the literature when there's just too much going on for a true systematic literature review. And our outcome was that there's really a lot happening. We had 406 studies included just in this, about a quarter of which had been done in the US, and the second most common in China, almost all of which had occurred in the last 5 years. They were mostly, again, as you can even gather from the things I've included in the stock, mostly fetal focused, aka what is gettable from sort of standard electronic health records, because also more than half of these weren't clinical and they were published actually in engineering journals. And what you find whenever you look through all of these is that truly everyone is getting into this space, but I will also highlight that they are doing so with two really significant issues. One, they're either applying AI and all of this fancy computational stuff and ultimately get very minimal improvement over what a standard statistical logistic regression type model did with all of that fancy non-explainable work. Or two, they're applying these models without frankly knowing anything about OB. So for example, one of the studies I've included on this slide used 3.6 million parameters to predict everything from maternal death to nausea to kidney failure to first trimester bleeding as a composite outcome. So You can imagine integrating that into your sort of first visit counseling, right? Like eat this fish, don't eat that fish. And now your risk predictor is high at 80%, which means that you're either going to be nauseous or you're going to have kidney failure and die. It is a very hard thing to use because obviously it wasn't developed actually with clinical care in mind. And so these ultimately can often feel a bit meaningless. Natural language processing studies, some more of the same, some very interesting, using SMM for risk stratification, our own work using aspirin for using a natural language processing to identify those who ought to be getting aspirin, and work done by our computational biomedicine folks here. We're using social media data as the new frontier of drug safety discovery, or even this really interesting one for querying childbirth narratives for PTSD. But I will say that, with all of those sort of pick from, what is, I get to pick my own and talk through, what does any of this really take to get it done? And so I'm going to talk a little bit, largely just by way of example, about our machine learning model to develop intrapartum predictions of the probability of a cesarean delivery. And you might think to yourself, we have so many clinical problems. Why pick this one? One is that, AI is actually, I would make the case, a very good thing to integrate for labor predictions. There are several characteristics that make it actually primed for it. So for example, there's multiple factors, and AI synthesizes things where there are multiple sort of collinear and disparate factors really well. Two, there's large amounts of data where nobody could possibly sort of use dropdowns for that sort of thing and be able to recalculate in real time. And then three, and this one's actually really important, the outcome is really clearly documented, right? So one of the classic things that you'll see in some of the other studies for predicting is like preeclampsia. And I always say to myself, that is so hard because number one, the diagnosis code is such a mess. That's oftentimes what you use for these things. And even before you get to the diagnosis code, you can ask one clinician, you can give them the entire patient's course and ask them if they was preeclampsia driving it, and they will tell you yes, and then you'll ask the next OB and they will tell you no. So I think, a really clearly labeled outcome is really important. And so in the context of our model, we really focused it at this 4-hour mark as, sort of our metric for whether it worked or not. We thought it was sort of in it enough that you were going to have some difference from the admission model, but still early enough that you were clinically agnostic. And we found that, we were nearly 90% accurate in predicting mode of delivery. But then importantly, we were really intentional also about how the model predicted. So the blue is when we were right, the red is when we were wrong. We most often predicted vaginal delivery and most often were right. We least often predicted cesarean delivery. And when we did so, the dark red there, we were very, very rarely wrong. And most interestingly, I think, it's actually running. So every single patient who walks into the CTRS labor and delivery has this personalized recommendation automatically running in the background. We're currently running it as I don't think let's see, little animation played. Oh, there it goes. That wasn't the animation. Well, I guess they were both animations. But it's running as a step wedge design. And so we're just showing it for a fraction of the doc sort of iteratively, but it auto updates in real time. And so, yes, this is not the relevant animation, but ta-da. And so even though that's oftentimes where these stories end, right? Like we're all good, AI has fixed everything. But what I really want to focus on for our last few minutes here, sort of epilogue to this, is when we enter this era that there are so many articles that were create these systematic or narrative reviews of these, we also need to be realistic. So another really key finding from our narrative review was that among these OB models, they are rarely truly validated. Only about 5% actually underwent external validation, mostly internal, and shockingly, 32% did no validation. And this is not just an OB problem. So if you look at this review of prognostic models, they talk about this data sort of leaky pipeline, and the issue being that so many models are developed that either don't do what we need, like those engineering ones I mentioned earlier, that aren't validated, like 95% of those that I described not being externally validated, that aren't implemented because the software to do so is just impractical, or simply aren't adopted because they just actually aren't that useful in changing care. Which leads to this larger problem, which is Karandeep Singh described in a talk I heard him give, who debunked the epic sepsis model, says models that are validated usually don't ever get implemented. Models that have been implemented were rarely well validated. And so it's with this in mind that we sort of start this final topic that, like, what must we get right? We that are going to sort of be the global we subject to all of these. We need clinicians like you and me to really stay engaged in this. So how do I sort of summarize what I think of this as pertinent to you on the front line? So I'm going to specifically focus on these particular concepts: target selection, implementation, and bias. And to start with target selection, I'm going to slightly modify the sentiment from Dr. Alice Walker, which is that we should look closely at the present you are constructing. It should look like the future you are dreaming. Instead, that we should look closely at the present models we are constructing. It should look like the future recommendations that we're dreaming. I don't think it's going to end up on any posters, but slightly modified. Or put differently, this is sort of a framework for sort of gut check for a should I use AI type Mad Lib? And I focus us here on this question. I would do blank differently. So we have to choose the target that we are modeling towards based on the behavior that we wish to change. So I brought up for example, our protometer earlier, and the way I often describe it is, yeah, we're going to predict the mode of delivery for your patient. The reality is one of our earliest questions we asked ourselves was, what are we going to model towards to reflect that a central goal of this model is to safely lower the cesarean delivery rate, right? Starting with the premise that the patient is sent to labor and delivery and that we're planning for vaginal delivery, and that over time, all of these factors sort of influence that care. How then does the partometer figure as one more influence in that? And our first instinct, admittedly, was to say, like, all the data, right? Like, AI loves data, let's just do all of the data. And what we quickly realized, though, was that had we done that, we wouldn't have actually told you whether you should have a vaginal delivery or a C-section. We would have just told you whether you would have had one. We basically just take the historical thing that would have happened to you and reinforce the same. We would not have actually improved or changed behavior. Our second instinct was to go guideline-based, but I would make the case that this was also not great because the guidelines themselves were really never individualized prediction, right? They were just normalization. They were just sort of taking who had fallen out of the sort of 95% confidence intervals to say, okay, you've taken too long, let's just go ahead and go forward with a section. Instead, what we built our model off of was clinicians with the lowest NTSV cesarean delivery rate, in the Lippers term singleton vertex, sort of intended for the non-OB audience to be sort of a standardized measuring stick across different clinicians. Which, swinging back to our central premise, suggests that by generating these quote unquote predictions off of this group, we would now be showing clinicians recommendations from this targeted group, a low C-section rate group themselves of providers, such that if they took the quote-unquote advice of that into account, we hypothesize that the end result would be a lowering of the C-section rate overall. So next, among the things that we have to get right, implementation. So as we develop these models, we have to ask ourselves not only whether the target is appropriately directed towards the target behavior, but beyond this, whether the data was extracted for use in any way reflects reality. Because we make this assumption that whenever we're sort of given this model, that this reflects reality and thus we can sort of implement it and disseminate it. But the reality, in fact, is that most of the models I've shown were either from beautifully curated research databases that look nothing like EHRs, and so they fall apart when you try to plug and play them. Or they were generated from real working EHRs, but like in the case of preeclampsia, the final target label is a diagnosis code, an ICD code that some coder dropped in at the very end, which is completely irreflective of the actual clinical course, but it's what drove the entire model development. And as a result, the assumption of how much truth at data extraction and recommendation the model shares with reality and implementation is just that, sort of an inherently flawed assumption. And then our next consideration for implementation, and this is sort of the piece that we're at in our C-section predictors, how do we actually effect change? Clinical decision support based on regression models has been in our electronic health records for decades, which means that we have also had clinicians ignoring clinical decision support for decades. So how do we do it differently for these AI-driven models that might be already less trusted? And so as we create these frameworks for AI implementation, such as this by Sendak, focused on design, evaluation, and validation, and diffusion, sort of holding always in our mind at the bottom there, this regulatory aspect, we also must have community, patient, and clinician involvement in their creation, or ultimately these models are never going to be meaningful. And then finally, for my last piece here, bias. And I call this section garbage in, compost out, to reflect that it's not truly garbage in, garbage out, because at least at the end of that sort of adage, you know that you're looking at garbage. The nature of AI models is that you might be delivered a product so obfuscated from what went in that we lack even the ability to recognize or criticize the model itself. I always get a lot of flack from my wife whenever I give this talk because she points out that compost is a good thing, but it's, anyway, we're going to go with the analogy for now. So this is particularly dangerous as we consider that these AI models, despite their reputation for impartiality, reflect goals and ideology and their blind spots, the judgments and priorities of their creators. So you can even hear it as I described my own model, right? So I inherently wanted to predict, to generate predictions that would lower the C-section rate. You code those in from the get-go. And Dr. O'Neill here, who's written this book called Weapons of Mass Destruction, she describes healthcare as being really perfectly primed to propagate these algorithms, because healthcare algorithms have the easy ability to scale, particularly again in an environment where a single EHR holds over 50% of the market. They can further mask their algorithms under the shade of HIPAA and proprietary considerations, and then also have the inherent potential for creating these positive feedback loops, in which bias is not only drafted, but potentiated and amplified further. And so as you consider what it takes to generate a model, starting from a sample of patients off of whom we build this data set, and it gets sort of this fancy split into the training and test, and then ultimately implemented, we have to consider that at every single one of these stages of data generation, selection, processing, and engineering and output, that there are potential sources of bias, and there's likewise no one size fits all for how to mitigate these. So sampling bias might be amenable to oversampling, which is great. But for historical bias, for example, I mentioned the VBAC calculator earlier, that's not going to help. You have to mitigate it from the outset. And I would suggest that this demands clinicians at the table so that the mistakes of our past don't become the quote unquote intelligent recommendations of our future. And my last little thing I'm going to highlight is that as we all sort of turn on what we think are these benign generative AI models, this is not just a rules-based models thing. So even as we see these sort of kind of nudge into every version of our healthcare, inbox auto-responding, ambient listening, we should all be very cognizant that they bake in their own bias. So in this example, investigators use matched guise probing to uncover differences in what these large language models, among them several of ChatGPT's, covertly perceived from language. Specifically, you can see here they use this meaning match set from two different sociolinguistically recognized dialects. What they describe here is Standard American English and African American English, and asked it a simple prompt. A person who says blank is what? Noting that the GPT judged those who spoke Standard American English more likely to be brilliant or intelligent, and those who spoke African American English dirty, lazy, or stupid. Even more disturbing is that would further transfer these perceptions to adjacent tasks. So they then said, okay, the only thing was heard that was heard in this sort of mock trial was this evidence uttered by a defendant. And what they found was that those who were speaking in the African American English, they increased the recommendation to convict for murder by 50%, and the recommendation for the death penalty was doubled. And note, whenever you ask any of these GPTs overtly which race is better, it'll of course tell you there's no difference, all of the things like I don't see color. But what we see in these large language models then is this shift from overt to covert racism, and that the shift further is exacerbated when human feedback is added. I would say, to end not on the worst note, but in some positive, the good news is that we can actually use AI to explicitly mitigate these, but it requires us considering them to build these computations in. So this was some work our group did regarding perinatal mood and anxiety disorders, recognizing that a risk prediction model being offered by the EHR vendor, marketed as intended to find those at increased risk, was going to be based off of those who had a diagnosis code of a mood disorder or a prescription. Anybody here can guess who actually provides clinical care? That's not actually the people I need to find, right? They got the diagnosis code, they got the prescription, the therapy. And so what we found was that when we instead switched it to a symptoms-based screening, which just based on the volume you can really only do with AI, we were able to not only maintain the same detection rate, but actually build in reweighing from the outset and reduce disparities in the demographic differences and reduce false negative rates across all groups. But again, doing so requires this like inherent subject matter expertise, local knowledge, and frankly, first and foremost, caring to take that extra next step to fix the problem rather than simply measuring what's easiest. All right, I think I'm beyond time. So in summary, I'm going to just sort of say here that I hope you've had a sense of sort of like a little bit of AI in general, the work being done in AI in medicine more broadly, and then in maternal health more specifically, and are able to consider some of these cross-cutting principles, target selection, implementation considerations, and bias as this AI makes its way into our lives, sort of large and small. And our final thought here is that AI is really not going to replace us, but I do firmly believe that the goal of AI should be freeing the clinician, whether it's through auto blood pressure titration or digital scribes augmenting our decisions to help us, to really ultimately bring the humanism back into medicine and to the care of the patient. As you can see here, just highlight to say that indeed the AI has gotten better. So with thanks then to all of the incredible people who have supported this journey, including both professionally and personally, my wife and 2 kiddos. And then I don't usually do the references as a list because there's just way too many, but rather you're welcome to use this link and it takes you to the actual Dropbox folder with all of the PDFs in it as well. And I can drop that in the chat too, since I think I'm going to stop sharing.
Amazing. Thank you so much. I learned so much during that time. Got some giggles in. Also, love how you really expanded thoughts as far as the pie in the sky and what we can do with this work. I know you have to run the clinic at the top of the hour. We do have a couple questions that came in. Put them into the chat. So real quick, which emerging AI tools in maternal health are you most excited about that are not yet widely adopted?
In maternal health more broadly, I would say that we are just starting to see them, in all fairness. As I sort of alluded to, there's literally 4 in OBGYN total, and only one of them is even pregnancy related. It's Perigen, actually. That's the one that's OB related, and you might tell my sense for whether or not it's really improving care. So I would say I think that there's just so much work to be done. I think that I do actually really endorse the operations tools. I wouldn't endorse is too strong of a word, but I do think that those actually have enabled us. I think that they're largely safe. In the case of digital scribes, for example, I think that we have to implement them in ways that we can continue to do sort of post-implementation monitoring. And I think that they'll help us just like they will a lot of other clinicians. As far as like actual like clinical decision support in maternal health, it's just still a pretty wide open space. Everything is really at the point of concept development. So for example, I saw a recent study on predicting preeclampsia, ironically, published in JAMA. And I thought, good for you, but we also have no treatment for it. So there we are. And it's one of those things where everything is still in that space, let alone to where I think we need to get to, which is actually like the implementation science around so many of these emerging AI tools. So I think that there's a lot to be done. I'm excited to see what we can bring to remote patient monitoring because I think and I sort of put that in the space between diagnostics or patient monitoring and operations because I think it sort of helps both. But I think it's really an exciting space to be working in.
Amazing. One last quick question before you head out. Keeping on the theme of, how quickly this has been improving the space of AI and as exhibited by Keanu Reeves, and thinking about, the pie in the sky, big dreams, thinking about 10 years from now, next decade, what breakthrough would you most like to see AI achieve for maternal health?
I would love to see us get really legitimately closer to personalized medicine. I think that there's a lot of groundwork, and it's almost like being able to see how the sausage is made keeps me a pessimist in this area. There's a lot of groundwork that needs to be laid. There's a lot of collaboration that needs to happen around, being able to harness that data in really meaningful ways. But I think that we can get there, and I think that we can do so in ways that are transparent for patients, for clinicians, and most importantly, I think have active bias mitigation strategies sort of built in. You'll find that as I sort of pick my projects, I usually tell people I generally start with, where there are inherent disparities in care, and the good news is in OB we have so many. So I do really believe in the potential, if we care about it, if we pay attention to it, to be able to actually bake in strategies to reduce bias. So I'll bring in one little mini example of something that we did related to like the lowest tier version of AI, which is just sort of clinical decision support to recommend aspirin for those at risk for preeclampsia. And we put in this super basic calculator, and essentially we're able to not only triple our overall rates of aspirin use, but also eliminate the racial disparity. And those are the sorts of things that we should do. Like nobody shows up to work saying like, I think I'll be a little racist today and recommend it, differentially for my Black patients. But rather, when you make it hard to do the wrong thing, you can actually improve care, and in this case, improve care for everybody, including the underrepresented populations.
Amazing. It's a really strong note to land on. Thank you again, Dr. Wong, for your time. Virtual applause. And I will go ahead and do our outro as we transition into office hours for all of our attendees. Thank you so much. As you will see in the chat, we do have a poll posted. So for those of you that are with us, please let us know how we did. Take our survey. Your feedback is important and always informs us on how we want to move forward with these sessions. So we got that going. We really want to make sure that what we're doing here at CTRC meets your needs moving forward. So as far as that, we do have ongoing support on our. Do we have a next slide, Jocelyn? Awesome, thank you. So for ongoing support, please check out our website at caltrc.org, where you can find our events, upcoming webinars. We have several on-demand resources, which we referenced during this session today. And you can also just reach out directly to us at caltrc.org, at ocean.org, and we can provide technical assistance there. And you can see we have every single way you can get a hold of us on all the socials here. We're pretty active there, and we hope to connect with you in that space. As we transition to office hours, definitely hope that you stay connected with us, as mentioned, and do want to plug that for our AI cohort series page, there will be the access to any recordings, slides, and other resources from our series. So all that right there. Thanks so much. And I believe that link is going to be posted in the chat on where you can see the other series from our AI cohort. So next we're going to welcome TTAC and have our open office hours. But again, just want to appreciate all you for spending your time here, and of course, Dr. Wong for sharing her expertise with us. So we have Calvin and Jordan on the call, and we're officially in our office hours. They're with TTAC, the National Telehealth Technology Assessment and Resource Center. Thank you both for joining us, and we are officially in our office hours session. I know we have a smaller group today.
Thanks, Rebecca. Not to gild the lily, but that was a fantastic session. I want office hours with Dr. Wong. That was amazing. So I do want to just caveat this. We probably can't answer questions in any of the depth around maternal fetal medicine and AI that we heard from Dr. Wong, but general queries, kind of next steps. We're completely here to answer any questions that you have, and then if we can't, we would love to get some information for you and get back with you. But we're your friendly neighborhood telehealth technology resource, and we're here to answer your questions where we can.
So I see we have 3 attendees left on the call. So I will invite, I'm going to call out now, Brian, Josue. We know Josue, we've worked with Josue in the past, and Vipula. If any of you 3 have questions, feel free to unmute. This is your time with either CTRC or TTAC to see if we can address any of your concerns or questions, comments.
Awesome. Thank you, Vipula.
Nothing from Brian. Agreed, Brian. Dr.
Totally
Wong
agree.
always brings amazing content, and she's so knowledgeable too in her specialty. Just brings the best of the best content. And it changes
So, Amelia,
rapidly.
would it be completely inappropriate if I asked a question that maybe we could kind of run through and see if we could get a response from Dr. Wong on? Just because it was something I was thinking of. I'm really curious is when we're dealing with like bias in these systems, if we're better off making larger, more complex AI tools that address the bias, or smaller, more focused tools that are keyed into populations that we're looking at. And I'm wondering from her perspective if one of those trends or a completely different way to address some of these bias questions is going to be the path forward.
Yeah, that's
What she was talking about with like using AI to detect AI bias in AI tools was just like, oh, okay, that's bending my mind around a little bit. But
it's
yeah.
fighting fire with fire, like it's that theory. Yeah, and I think it's an important conversation that sometimes is missed when we're discussing AI, is the inherent bias that's built into some of the models just because there's a lack of data. And as humans, we're so diverse. And so you need, sort of a large data set to be able to feed into those models. But yeah, I think that's a great question for her from her perspective and where she sits, getting her to weigh in on.
My mind in this arena goes to payer approval models, and what their initial driver for generating the models is in the beginning, right? Is the initial bias that they fed their AI model for approving procedures reduce costs for the company, or is it provide appropriate care? And then are these models self-reinforcing whatever bias or intent was initially fed into the systems?
Because you have denied a thing doesn't mean you should deny a thing.
Right. Or what was the patient outcome post your approval, right? Like, ethical payer practices, which I'm sure is a contradiction. So.
Something I think back often is during our CTRC summit in June, Dr. Jonathan Chen made a comment that these models are built to be likable, to be agreeable, to do what you want them to do, despite being incorrect or wrong. And that leads to their popularity even more, right? Like to just AI in general even more. And it's something I think now I see AI output and generation so much through that lens because of that point that he made is, do I like this because it's designed to make me like this output, or do I like it because it is in fact accurate and impactful?
No, and we like things that make sense. And so if we get a response back and it like lines up with our preconceived, like, oh, that makes internal logic to me, we're gonna glom onto that, even though that may not be the key thing that we're supposed to factor in. So it's all of these little like subtle behavioral reinforcement things that these tools can do to really, because they're reflections of us. So they're the casual racism that's in the data set is the casual racism that's like kind of embedded in society, and the bias for having people tell us things that we're good and that we're great and that like that encouraging us is the need for us to have people tell us that we're good and we're great and that they like us. And so because it's exactly what was being described. It's the next word. It's like, hey, what do people want? What's the next thing that they want to hear? And I think that unless there is unless people really understand how these tools work, and they think that it's coming out just like it's not. It's built to be sticky, and it's very, very sticky. And like separating the stickiness from the underlying benefit is an important skill for us to all to learn.
Yeah, my mind goes to, the recent Meta settlement against the federal government, and, how their platform was intentionally sticky, using your word, Jordan, and that these tools were developed by similar companies with similar purposes, with the output of the interaction being advertising. And so I just, I question the underlying intent of a lot of these generative platforms.
And again, I don't even know if it's that nefarious. I just think whenever you have large data sets, it's trained on the data sets that exist, and the data sets that exist reflect the populations and kind of inherent biases and the way people are. And so it's not surprising, in a lot of situations where, yeah, who doesn't like to be praised, or to feel special, or like those are the sorts of things that we're seeing in these data sets. Or who doesn't like to have their lives made easier and to be given an easy option and be able to select something from a list of choices, rather than having to go in and ask harder questions. And so I don't know if it's a nefarious, but I do think it's just, it kind of reflects the people. But I don't know. Are we wandering too far afield?
No, I always love this sort of dialogue. And when we get into these types of conversations, I always think, my grandma's going to love this that I quoted her today, but she always says, like, any tool's a weapon if you hold it right. And this always, like, when we start talking about this, it's like, AI can be such an impactful tool, but it can also just be used nefariously, like you said, whether it's intentional or not. Sometimes I think that all tools have that ability to be used for good or be used for evil. And so I think AI aligns so much so in that space of it being a little bit of a blurred line sometimes, because we as users have to have that discernment to understand, what right, wrong, what's accurate, what's not accurate, what's a hallucination, et cetera. And I think we're all sort of developing that AI literacy on the go. It's not something that I think we're inherently trained to do. I think none of us went to school for that. We're not formally trained in that space. We're just learning as we go.
No, and you're absolutely right that this next generation of digital literacy and like these digital skills that they actually almost come down to rhetoric, right? Like, what is actually being said? What is the intent behind what is being said? And how do I parse this in a way that, like, I understand the meaning behind the meaning? Like, those are all skills that, like, were were not enforced within the last, like, many decades. But I think those are all skills that we're having to dust off and to figure out, like, hey, how do we really critically look at some of these things? It's fascinating. And I completely agree. I think how we are teaching people to think about tools and technology, and the way that these things are going to impact ourselves and the people that we care about, is going to be one of the biggest changes. And it's not a skill set that exists widely and broadly. And it's also something that we can't just completely say, like, oh, we'll build a tool to be ethical and insightful and like find problems. The tools can help, but we'll have to know, like, a friend of mine, like, how do we give these resources the sniff test, right? Like, how do we just say, like, this seems good, this seems bad? Because we're not going to understand the network, or, you know, kind of how the output was arrived at. But how do we understand, like, okay, this feels correct, or this doesn't feel correct, and build those skills? It's going to be an interesting time.
Yeah, could talk about this all day. But with that, we'll wrap up at the 11:15 mark right now. Thanks again all for attending, and big thanks Jordan and Calvin for joining us in TTAC and for the discussion. Right.
Thank you
Take care.
all. Thank you so much.
Thank you, everyone.
Excellent
Thanks
session.
all.